So while the panel is coming up, I'll try to get some quick ones out of the way that have come up. Dr. Halpern, from who do you send your under 18s to who have NETs?
That's a rare population, but our pediatric oncologists are outstanding, and they're sort of expert in how you take care of younger folks with cancer, and then we get involved for sort of technical questions.
And many people also send them to Pseudo in Iowa because
Yes.
she specializes in the...
Yep.
So depending on where you are, if your pediatric group doesn't really do that as well. So this is a little bit earlier as well, but we can talk about biopsies and genomics, and also, if you were... these are two of how do you talk to your physicians about maybe going elsewhere if they don't have a lot of experience. So this is between how to ask your oncologist maybe to have something somewhere else, or how do you politely ask someone to get a specialist?
I would just respond to that. Who are you looking out for here? You're worrying about someone else's feelings when it's your body, your health, your future, your life. So I would start with that premise, and then also say that as a physician, I'm not offended if somebody wants to seek a second opinion. I encourage it, and it's not an affront to have somebody say, look, thanks, but I think I'm going to go and see someone else. That's fine. It's your freedom. You should be doing that.
I would go with that. So one of the things we talked about was sequencing a little bit here, which is a lot that we just don't know yet. And so I wanted to put up the kind of sequencing question. There's just more than one set of sequencing questions, of course. If we look at this, it's, we have medication research. I know this was one of our table topics. Do we ever think of PRRT first or other? How do we determine what is the next best second-line treatment? How are we doing trials for this? And I know we mentioned PFS earlier, or progression-free survival. Do we just look at the drug with the longest progression-free survival, or what is wrong with that?
No.
I like that answer. Continue.
So when we do
glasses, I like that.
The glasses are, well, because the math is going to come out, so the glasses have to come on. So no, when we do clinical trials, right, you can't really compare the progression-free survival that you see in one trial versus another trial, and this is probably doubly true in the neuroendocrine field compared to other cancer patients that we might see, because the mix of patients in the clinical trial is always proprietary to that clinical trial. So you may have inclusion criteria that say we'll put a bunch of patients with grade 1 and grade 2 neuroendocrine tumors in the same trial, but if one trial is all patients with grade 1 mid-gut neuroendocrine tumors and the other is all patients with grade 2 pancreatic neuroendocrine tumors, the PFS is different in the control arm regardless of what the drug is. So you can't just go by whichever number is bigger.
So in case of NET1, we had a positive trial, so that's all we really know. We have positive trials on certain drugs. We don't know how they do compared to other drugs and in which order, not yet. What will it take for us to figure that out?
It will take a 5 factorial arm clinical trial to tell you which sequence is optimal.
There's never going to be the perfect trial to tell you which sequence of treatments is optimal. By the time you had enough patients enrolled in a trial like that, another treatment will have been developed and we'll be starting all over again. So
it wasn't one of your Kiwi doctors, but I did listen to an Australian doc who said, we have to live with some uncertainty. There are just things that we are never going to, and it's really hard for patients to deal with uncertainty, but uncertainty is part of this. We just may never know some of these answers, and we're going to keep working through it.
But I also think a very viable question is, just because a clinical trial tells you that arm 1 is best on average for most people doesn't necessarily mean that it's specifically the very best thing for your particular situation, and there's always going to need to be some nuance in clinical decision making.
And I see it as moving goalposts. just when you get your head around how things might be optimally organized, something else comes along, so the goalposts have shifted. The PRRT is approved on the basis of the clinical trial here in the States for people who've progressed after standard of care. We don't have any evidence base for whether or not it might be better earlier in the course of disease. But if you take a big step back and say, new drug, where does it fit? We always start with the scenario that the new drug is for the people who've failed every other drug.
Patients don't fail drug. We may not.
All right.
We never fail a drug. The
word.
drug may not work for us, but we've never failed a drug yet.
For instance, in New Zealand, the statin medication for cholesterol lowering was only ever approved initially for people with hereditary high cholesterol syndromes who had heart attacks at the age of 25. And here we are less than a couple of decades later, where its approval and indications are much more broad for treatment of cholesterol earlier on.
This is another question to me that's uncertain and depends on where it is and where you are in your treatment. Is there any optimal imaging, and which and when are things better, whether it's for GNETs or lung nets, or GEP-nets, I should say. But, you know, I will say there are some guidelines for neuroendocrine, for somatostatin analog positive. They're sitting out on the LACNETs table for the appropriate use criteria for gallium-68. But what do you tell your patients? I know following up with conventional imaging versus molecular imaging.
I would say the least amount of imaging for the most amount of information is what you're aiming for. So to try to be as efficient as possible to get your clinical question. Never do an imaging study just for interest. You need to know what you're going to do if you find a positive or a negative. It needs to be impacting a management decision rather than just for interest. Otherwise you get into trouble with.
But is there any perfect one scan?
No, there's no perfect one scan, not for this or any other disease.
Let's see if I got that right. No, I didn't get to the right one. Hold on one second. Let me get some more questions up there. I see that one. Oh, there we go. Little bit on the genetic side, talking to about our parapheo groups and other ones with different genetic mutations. And are they NETs when they have these certain mutations? So do you want to speak a little bit to the genetic side of this?
So the SDHB, or succinate dehydrogenase, certainly is a common mutation we see in GIST tumors, but I don't really see that much in neuroendocrine tumors. So she had 7 tumors removed last year. She was always told she wasn't a NET patient. Recent NET spotlight up. I'm going to have to defer that to Dr. Thompson. That could be a very non-specific finding. I think it's important to have biopsy confirmation, as always, to truly determine what type of tumor you have. And if they are also asking a question about should this warrant genetic counseling, it really depends on the risk factors of the family. If they truly had a family history of malignancies, their age of diagnosis is something that's also important to determine, because the younger they are, we tend to have them see the genetic counselor for evaluation.
Yeah, I think the simple answer from my perspective is the pathology, the biopsy is what proves whether it's NET or not, and GIST is not NET, not a scan. So there could be something else going on, it's impossible to say, but the GIST didn't become a NET when the NET spot became positive. It doesn't only spot NETs.
So we do have some parapheo question as well, and thought we might take a look at that.
The radioactive material for treatment of metastatic Pheochromocytoma is market approved and available in some facilities. It's a radioactive iodine. We have not set up a program to give that here. And some of these people are, we're seeing very positive NET spot scans and delivering treatment using the Lutathera for metastatic paraganglioma. And it's complicated. There's pros and cons of the different treatment approaches, and it's also messy in terms of what the scientific basis is supporting the best treatment long term.
Well, so often we get, they don't light up with the NET spots. We can't image them. We know, and I'll get one else there, where they're having symptoms. We think there's something around. Are there other imaging modalities? We've talked about conventional imaging. What else besides a NET spot might work for a full body scan? Not sure that it will, but.
You can't really do a whole body MRI. Well, I guess you can do anything you want to do, really, but you do a whole body CT scan, that's an awful lot of radiation. Probably the biggest bang for your buck or the best efficiency is going to be with a whole body NET spot in someone who has symptoms, tumor markers positive, and nothing else that localizes where it's coming from. It's a whole different story if someone presents with abdominal pain and you can target your imaging evaluation for just the abdomen. But when it's not clear, then a whole body scan is good.
So Dr. Halpern, we kind of talked through this. Would you have sent someone who has flushing and normal serotonin for gallium-68 when you didn't see anything else going on? Or how do you deal with things when you have patients who have symptoms?
Yeah, I mean, and this is one of the really difficult things about clinical medicine is it doesn't always make sense and work out the way that we want. As an oncologist, sort of my training is, in order for me to say that you have a tumor, I need to see that tumor in your body and see a pathology specimen confirming what the tumor is. And it's very, very difficult. I would never say impossible because we have to remain humble, but it's very, very difficult to have carcinoid syndrome for a neuroendocrine tumor without being able to find that tumor at all and prove that it's there.
We do see people referred for a scan using the gallium-68 where this is the sort of scenario. And the yield, the diagnostic yield, meaning the likelihood of finding it, is extremely low.
The
vast majority of those
paper
scans
from Iowa
are frustrating. They're negative.
And I know we didn't get into in your symptom management, but lanreotide and sandostatin are two somatostatin analogs. We have a question, the last question we'll take from the audience right now before we start the insurance part is one better than the other, or what makes them different, and how does that affect patient care?
Yeah, I mean, so I do often call these Coke and Pepsi. They really are just a couple of amino acids different. The pharmacokinetics, meaning sort of the peaks and troughs of the chemicals in your blood, are a little bit different, and the absorption can be a little bit different. So there are some clinical scenarios where it's favorable to have one or the other, but I think for the vast majority of folks, really the primary difference right now is cost. And that's sort of an individual thing with people's insurance and their doctors and so forth that isn't really the focus today. But I think for most folks, the primary driver is cost.
I think this is one of the perfect ones where there were two clinical trials and one had widely different PFS from the other, and yet even the placebo arm was greater than the treatment arm of the other.
So if I may push up my glasses just for a moment there, Josh.
Dramatic effect, I like it.
So, when we talk about sort of the benefits of therapies and clinical trials, I actually make a point of never looking at the absolute number of the PFS and rather looking at what's called the hazard ratio, or the ratio of benefit of one therapy over the other. And what's really interesting, if you do that with octreotide and lanreotide, which you have to commit another data analysis sin in order to do, which is a subgroup analysis. But if you ask, what was the benefit for patients with mid-gut neuroendocrine tumors in the Promed trial of octreotide, the progression-free survival hazard ratio is about 0.35, so a 65% reduction in the risk of progression or death. And if you commit the sin of looking at the mid-gut neuroendocrine tumor patients in the clarinet study of lanreotide, what was it? It's about 0.34. It's a 65% reduction in the risk of progression or death. So again, they're Coke and Pepsi.
I want to really thank this panel for coming back up. This was kind of really fast because we want to get a little bit back on time. So I know you're up and doing some introductions, so thank you.